Hello everyone, I'm Dr. Surekha Tawar, second year postgraduate from Department of Oral and Maxillofacial Surgery. Today we'll discuss about maxillary sinus and its complications. The contents of the seminar will be introduction, development and anatomy of maxillary sinus, blood supply, nerve supply and lymphatic drainage, histology, functions, diagnosis, and the complications of maxillary sinus, which includes maxillary sinusitis, oroenteral communication and fistula, and their management. The paranasal sinuses are air-filled spaces located within the bones of the skull and facial bones. They are centered on the nasal cavity and have various functions, including lightening the weight of head, humidifying and heating inhaled air, increasing the resonance of speech, and serving as a crumple zone to protect vital structures in facial trauma. The four sets of sinuses are paired, and they are frontal sinuses, sphenoidal sinus, ethmoidal sinus, and maxillary sinus. We'll discuss maxillary sinus in detail. Maxillary sinus is a pneumatic space that is lodged inside the body of the maxilla and that continues with the environment by the way of middle meatus. It is the first sinus to develop. Maxillary sinus starts with a shallow groove on the medial surface of the maxilla during fourth intrauterine life and reaches to maximum at around 18 years of age. The expansion of maxillary sinus occurs more rapidly until all the permanent teeth have erupted. At birth, the maxillary sinus is an oblong cavity which is tubular in shape. In the early childhood, the floor of the maxillary sinus is above the floor of the nose, and the teeth develop. The growth of alveolar process takes place, and the floor also starts descending down. At around 12 years of age, the floor of the sinus is at the level with the floor of the nose, and in adulthood it becomes pyramidal in shape. The anatomy of maxillary sinus was given by Highmore in 1651, so it is also called as antrum of Highmore. It is the largest of all paranasal sinuses and communicates through nasal wall. Horizontal, pyramidal shaped with base, apex and 4 walls, so in total it has 6 walls. The anterior wall of maxillary sinus is formed by facial surface of maxilla. The posterolateral wall is formed by zygomatic and greater wing of sphenoid bone. The medial wall is formed by lateral nasal wall. The floor of the maxillary sinus or the inferior wall is formed by alveolar process of the maxilla carrying the roots of molars and premolars. The superior wall is formed by the roof of the sinus and floor of the orbit. All the walls can be clearly seen in this picture. The posterior-superior part of the lateral wall in the inferior meatus is the thinnest area and is preferred site for nasal enterostomy. The blood supply of the sinus is from facial, infraorbital, and greater palatine vessels. Pterygoid venous plexus, sphenopalatine vein, and facial vein controls the venous drainage of the maxillary sinus. Nerve supply to the maxillary sinus is majorly from the posterior, middle, and anterior superior alveolar nerves, which are branches of maxillary division of the trigeminal nerve. Infraorbital nerve and greater palatine nerve also contributes to the nerve supply of the maxillary sinus. The lymphatic drains into submandibular lymph nodes and deep cervical lymph nodes through infraorbital foramen or ostium. The sinus depends on the action of the cilia for its drainage. The lack of ciliary action leads to stasis of secretions, which leads to infection of maxillary sinus. Maxillary sinus is lined by the 3 layers, that is epithelial layer, basal layer, and subepithelial layer with periosteum. The rhythmic beating of the cilia is responsible for the drainage of sinus against the gravity. The epithelium is pseudo-stratified columnar and is ciliated in nature. The functions of maxillary sinus are humidification and warming of air, assisting in regulating intranasal pressure. It helps in lightening the skull to maintain proper head balance. It imparts resonance to the voice, absorption of shock to the head, and the filtration of the inspired air. The clinical examination of the maxillary sinus can be done extraorally, intraorally, or through transillumination test. In extraoral examination, we check for pain and tenderness and swelling over the cheekbone. In intraoral examination, we check for pain and tenderness over the maxilla between the canine fossa and zygomatic buttress. Good transillumination indicates the presence of air in the sinus, while the failure of transillumination indicates the presence of pus, fluid, solid lesion, or mucosal thickening. Radiographs are the most important investigation to examine the sinus. The intraoral views we use for maxillary sinus are occlusal views, periapical view, and lateral occlusal view. The extraoral views are occipitomental view, Waters view, lateral skull, orthopentamogram, and computed tomography. Now the complications of maxillary sinus. Maxillary sinusitis is the inflammation of the mucosa of the paranasal sinus. It is usually odontogenic in origin because of close approximation with maxillary teeth, and it occurs secondary to allergy or infection. The sinus lining becomes edematous, inflamed, and congested, which leads to excessive secretion of mucus, loss of ciliary action, stasis of secretion, and secondary infection. The exposure of sinus during trauma may also lead to sinusitis. A chronic periapical infection leads to destruction of intervening bone, and infection may enter the sinus. The destruction of the floor of the sinus by tumors can also lead to the infection of the sinus. Maxillary sinusitis can be acute, subacute, or chronic in nature. In acute, it is of sudden onset and the duration of 4 weeks. In subacute, the duration is of 4 to 12 weeks. In chronic, the duration is of 12 weeks or more than that. So this is a picture showing healthy sinus and sinusitis in the case